പതുക്കെ തുടങ്ങിയാലോ സാറേ?
ഒരു മിനിറ്റ് വേണം, ഒരു മിനിറ്റ്.
ഓക്കെ. സ്റ്റാർട്ട് ചെയ്യാം.
Okay, okay.
Harikin sir.
Yes.
Okay. So good evening everyone. Welcome to this panel discussion on COVID vaccination. Whenever we had conducted a session as a refresher session on COVID, when we were struggling with the second wave, always we ended up with few of questions regarding vaccination. That is how we thought of dedicating one whole session for this COVID vaccination, because there are lots of doubts in the minds of each and every stakeholder who is involved in COVID vaccination, be it be a faculty, a student, or any other healthcare worker. So we thought of slightly expanding our session who is experts. Okay, and we ended up with a panel discussion, and we are very happy to have a big eminent panel with us who are voluntarily come ahead, ready to answer many of your doubts. Okay, so rather than having a conventional session where usually the speaker speaks with the help of a PowerPoint session, this is more going to be a two-way discussion, question and answer session. Whatever is possible from our panelist side, I think they will be able to answer your questions. So please feel free to make use of this facility. Okay. So with this few words, I'll hand over to Harikrishnan sir, who has agreed to be the moderator for this panel discussion. So over to you, sir, to introduce the panelists and move on to the discussion.
Thank you, Dr. Sarada, for that warm welcome extended to all of us. First of all, let me introduce my panelists. First of all, I would like to invite Dr. Srikumar, Senior Scientist from a Molecular Virology Department of the Rajiv Gandhi Institute of Technology from Trivandrum. We welcome you, sir. I think it's the first time we are having you here in Kottayam Medical College program. Yes, so thank you, and very nice and happy to have you here, sir. And we value your expert opinion. So I hope that this will provide a very interactive occasion. And let me also introduce and welcome Dr. Sitara, who is our district surveillance officer and who's been working very closely with us, especially the Department of Community Medicine and Department of Infectious Diseases, right from the beginning of the COVID epidemic back, I think from February 2020. I think virtually every day, every evening, we used to have regular telephonic conversations on the matter of COVID. So welcome, madam. And madam, we are hoping that she will give us more insight into what our district vaccination plan is, how we plan to move forward, and how many more people we plan to vaccinate in the near future. What are the other options for vaccines, etc.
Thank you, sir.
I also would thank you. It's nice to have you here. I'd also like to introduce from our own community medicine department, Dr. Anupa Lucas, and hi. Dr. Anju, both of who are involved in the vaccination effort in our campus. So they are the members of our team who coordinate providing vaccines from our facility in Medical College Kottayam, and most of us who went there to have a jab usually had an interaction with either one of them. And so from what happens from the end user point of view, when a person who wants to get a vaccine or who has a date for a vaccine goes there, what happens, what are the problems they face there at the vaccination point, and what are the common queries which are raised from the end of the patients, and what happens there. All these things, I hope they will enlighten us and give us more knowledge. So I welcome both Dr. Anupa and Dr. Anju to our session. I welcome both of you.
Thank you, sir.
So, so I will first of all just kick off, even though it is, as I said, not basically a lecture like session. I'll just kick off with a brief overview of how far we reached as far as vaccines are concerned, the bare skin and bones of what is happening, and then we'll go on to to further discussion on the topic. So let me just share with you a few slides on that. And I promise you that I'll just get through these very quickly as possible. Okay. Is my slide visible to you? Yes.
Yes, sir. Yes, sir.
Right. Yes. So to start off, I just give you a brief overview of our present position. As we know, the COVID vaccination program started on 16th Jan in India. And obviously, the first priority group was healthcare and frontline workers. And from March 1st onwards, people over 60 years of age and persons between 45 and 59 years of age with comorbidities could receive the vaccine. And we had an annexure form to fill up regarding those comorbidities. From April 1st, people above the age of 45 years were targeted. And from May 1, all eligible citizens above the age of 18 years. Now, having said that, obviously, there have been a few fits and starts and stutters, but the program is going on. Now, in the initial days, when the time came for the healthcare workers and then later for the people above the age of 60 years, initially we had what is called as vaccine hesitancy. People were very reluctant to come forward and take the vaccine, even among doctors. People had this great reluctance to come forward, and I remember we held sessions here in order to overcome that vaccine hesitancy and get more people to take the vaccine. But now we have reached a stage of urgency where people are desperately running around for the vaccine and trying to register in the COVID portal and not trying to get a slot, etc. So we have moved from one end of the spectrum to the other. Now, if you look at rough estimates of India's vaccination drive, we know that we are in for some problems because The government target is to vaccinate about 300 million people by 15th of August. And given the present supply estimates and manufacturing estimates, we might fall short there. And even at the end of the year, by December, there might be a shortage of as much as, let us say, 576 minus 120 million doses short. If we don't do something about that very quickly, there's going to be a big gap between the actual number of doses of vaccine available and the number of people who we are targeting to vaccinate. And that is reflected in this number too. As you can see, we have vaccinated less than 4% of people after going into, I think, about more than 5 months of vaccination, whereas a lot of countries which have done much better than us. But the part of that has to obviously do with a huge population and the heterogeneous aspect of that huge population. Okay, when we come to vaccines, I mean, the virology will be discussed in great detail by Srikumar sir, but still, just to get the ball rolling, I know that most of you are aware of the basic things about the vaccine. We have two basic way of doing things. One is to somehow get the spike protein into the body, or get the body to manufacture spike protein and then get antibodies against it. So we have three vaccines which do that. We have Oxford's the AstraZeneca vaccine, which is manufactured locally by SSI, Serum Institute, as Covishield. Then we have Sputnik 5, which is coming in, and then we have Pfizer BioNTech, which uses the mRNA for the spike protein. So what all these do is basically get the genetic material for the spike protein into the body and then try to elicit an antibody response. Whereas Covaxin, which is from Bharat Biotech, is a whole inactivated. It's a more traditional way of making a vaccine. Inactivate the virus, inject it, and get the antibodies. So these are some of the vaccine candidates which are available and in play. We have Covishield and Covaxin already in our basket. Then the Sputnik 5 is coming in. There's a collaboration with Dr. Reddy's, and they're starting to manufacture it. And already major private hospitals have ordered large quantities. We have Janssen, which is by Johnson & Johnson, which is Dutch, Belgian, US vaccine, which is almost, we can say, a combination of the Sputnik vaccine and the AstraZeneca vaccine. Details, I'm sure Dr. Srikumar will tell us. And then we have the two mRNA vaccines, which are very popular in the US, the Pfizer as well as the Mrna Vaccine. What vaccine country chooses and what vaccine India chose also depends to a large extent on how well we can store it and distribute it, and what is the pressure which is put on our cold chain. As you know, our Oxford AstraZeneca vaccine, which is the Covishield, requires only 2 to 8 degrees centigrade. So does Covaxin requires only 2 to 8 degrees centigrade, whereas the mRNA vaccines require much more stringent temperatures for maintenance. So that's perhaps one of the reasons why we went for those two vaccines initially, but we are hoping that our vaccine basket will expand over time. Now, what is vaccine efficacy? Everybody wants to know. They want to compare Covishield versus Covaxin and all those things. What do you mean by vaccine efficacy? Efficacy is a percentage reduction of disease in a vaccinated group of people compared to an unvaccinated group. So you give the vaccine and find out, how many people are protected from the disease. Now, the FDA and European Medical Agency has set a cutoff of about 50% as the efficacy required for approval of COVID vaccine. And most of the vaccines that are available have efficacies of more than 50%. And as far as to prevent herd immunity, etc., or to acquire herd immunity is concerned, probably we would require vaccine efficacies of roughly 6 to 7%. The concept of sterilizing immunity, I think, will come to later on after our discussion on molecular, the virology of the vaccine. And if you look at the vaccine efficacies of Covishield, less than 6 weeks interval, that is interval which most of us have it taken it at 4-week interval, the vaccine efficacy roughly touches 53.28. Whereas if you take it at 12-week interval, it's about 78%. Modern figure, newer figure, these are all old figures from January. This is from the package insert of Covishield. Now, newer figures keep the Covishield efficacy at somewhere roughly around 81 to 82%, which is usually consistent across most studies. Now, Covaxin does not have too much published data about efficacy, but some interim analysis tells us that its efficacy is also about 81%. Look, if you look at the mRNA vaccine, several studies which are available from the US tell us that they have an efficacy of 95 to 96%, both of them. That is both the Mrna vaccine as well as the Pfizer vaccine. So what are the contraindications and special precautions? We have not yet started vaccinating people below the age of 18 years because there's no data. So people in that age group are not enrolled in trials. And therefore we don't have much data, so we are waiting. And moreover, in most pandemic situations, this is what is done. Usually the older people are vaccinated first, and then we bring it down age group by age group, and then finally we vaccinate children. Now, pregnant women and lactating mothers, we will go into that in a bit detail later on. Right now, our vaccines, both Covishield and Covaxin, are not indicated in that group, both pregnancy and lactating mothers, much to the distress of our colleagues in the obstetrics and gynecology department, because they are seeing a lot of COVID positive mothers whom obviously management is difficult for various reasons. Obviously, hypersensitivity is an obvious contraindication. Now, concurrent illness immunosuppression might reduce the efficacy of the vaccine from the stated percentage in trials. And people with severe bleeding disorders need to be very careful. But people who are on blood thinners might just continue the blood thinners and then take the vaccine. There's no contraindication. A very commonly asked question is, patients having active symptoms of SARS-CoV and people who have been given monoclonal antibodies or convalescent plasma, when should they receive the vaccine? Roughly around 4 to 8 weeks after symptoms or after taking the antibodies or the plasma, right? Now, vaccine reactions, you can have immediate reactions which are allergic, IgE mediated, etc., or delayed site reactions. But for example, these are the most common. We will hear more about the vaccine reactions commonly encountered by Dr. Anuba and Dr. Anju. Anyway, these are the commonly encountered ones immediately after or in the first 1 or 2 days after the vaccine has been taken. For example, nausea, injection site problems, headache, etc. Now, some data on, we talked about pregnancy, and this is from the mRNA, pregnancy data from mRNA vaccines. As I told you, as far as Covishield and Covaxin is concerned, there is no pregnancy data because pregnant patients have not been enrolled. But there has been some studies on pregnant patients who have received mRNA vaccine. And if you look at the safety profile, pregnancy loss, spontaneous abortion, stillbirth percentages, preterm birth, etc., there's no difference at all between the group which has received the vaccine and the group which has not. And this again, I think, will come to later on. Now, another adverse effect which we talked about a lot during the early days of Covishield was obviously neurological symptoms. Trials were stopped in some countries because of GBS-like symptoms and transverse myelitis, but then because no definite causal link was established, vaccination was continued, and we have not seen any such case as far as our hospital is concerned. Now, this is slightly more important than the neurological manifestations. Arterial events, venous thromboembolism, and thrombocytopenia. So, especially in the northern European population, as well as Austria, Germany, and some other countries, they noticed that there was an increased incidence of thrombosis, both arterial and venous, but mainly venous thrombosis, cortical venous sinus thrombosis in patients who took the Oxford's vaccine. That is, as far as we are concerned, the Covishield. But then later, a huge analysis showed that the risk of venous thromboembolism associated with the vaccine is not higher than that of the background risk in the general population. And obviously, the benefit versus risk is hugely in favor of taking the vaccine rather than not taking. And in those countries which delayed taking the vaccine for 2 weeks because they wanted to wait and evaluate this problem, all of them had huge second waves, so the delay actually cost them a lot. So this is what we are talking about as far as the side effect is concerned. Major side effect, it is probably due to antibodies to platelet factor 4. So patients have thrombocytopenia, cortical venous sinus thrombosis, Budd-Chiari syndrome like presentation, pulmonary embolism, etc. And this, in the patients in whom it has occurred, it is usually treated with oral anticoagulants, not heparin. Platelet transfusion should be avoided. IVIG is also useful. Another question which is commonly asked is, should I mix and match? This is some new data which has come in. That is, suppose you take one dose of Covishield and the other with Covaxin. What is going to happen? Is your immunity going to be better? So it's called as prime boost regimen. Prime with one vaccine and boost with another. So is it going to be more beneficial than giving 2 doses of the same vaccine? So these are all questions which need answering. And on that note, I will stop my presentation there, and I will hand over to Dr. Srikumar. Sir, especially the last bit, could you address those problems from your point of view?
Definitely, I'll mention that also.
So over to you, sir. Over to you. So please take up.
Thank you, Dr. Harikrishnan. So I think the presentation is visible and I'm audible.
Yes, sir.
Okay. So while talking about the vaccines, I just wanted to start with the basic host defenses, like which all of us know, the intrinsic, the physical chemical barriers, the innate immune system, which is the first line of immune defense, and the adaptive immune system. See, in the whole COVID scenario, one thing that gets very less attention is the innate immune system, which has major implications in the clinical progression of the disease. And maybe we need another session to discuss on the first line of immune defense, how it can prevent the severity of the disease. Now, talking to the adaptive immune system, which all of us know that it is tailored to the pathogen. And one major outcome of this COVID pandemic is that from the conventional live attenuated, inactivated kind of vaccine scenario, we have moved drastically to the new generation vaccines. And even though these vaccines may be they are in the laboratory for the last 20 years or more in different stages of clinical development or maybe preclinical development. No one was in a very comfortable environment to try them in the clinical use. But this COVID pandemic has compelled us to test this technology, and now we see that it has proven beyond doubt that it can be a major breakthrough in the vaccinology. And there are the common vaccines that we see now is the vector vaccines. And interestingly, all the currently available vaccines are non-replicating viral vector vaccines. And there is a parallel a replicating viral vector vaccine, which is some companies initially they wanted to start with that, but they don't stop developing the replicating. So the major difference between these two vaccines, as you can see, the non-replicating one, whatever the amount of the encoded antigen or nucleic acid that we are giving into the individual, it remains constant, and that elicits an immune response. There is no increase in the amount of the antigen material. But in case of replicating vector, you can see that the vector virus or the organism will go inside and replicate, and there will be an increase in the amount of the antigen that is presented in the system. Definitely, since the antigen amount is going to increase in the patient or in the individual, this will be more immunogenic, and also like we may have to give only a low dose initially for this, and maybe even a little bit of loss of the vaccine antigen may be okay in this kind of vaccines. But here it becomes the storage conditions and all that becomes very crucial, because whatever the loss that happens during the storage conditions may affect the immunogenicity of the vaccine. New vaccines are coming up with the DNA vaccine as the backbone, and RNA vaccine. Definitely we have the mRNA vaccine where we have the naked mRNA, which is enclosed in a lipid, enclosed in a lipid nanoparticle, and which is delivered into the system. So the lipid envelope facilitates the entry of the mRNA into the cytoplasm of the cell, and inside the cytoplasm, I'll explain a little more detail in the coming slide. So this new generation vaccines have given a lot of hope to the scientists as well as all the medical community, because of the large number of emerging infections which are threatening the mankind. And the major advantage, unlike the polyvalent and multivalent vaccines that we had previously by mixing different vaccine antigens or components together, we can have a single vector which contains all the immunogenic regions of the pathogen, so we can tailor it accordingly. And already there have been a lot of new initiatives that is happening to, for example, to club the chikungunya, dengue, all the 4 serotypes of dengue, maybe Zika virus, and all those, maybe it can be clubbed with corona also. So like that, people are now trying multivalent vaccines, or which incorporates the genomic segments coding for the immunogenic proteins into a single platform. So this is gaining momentum because of this new generation vaccine initiative. And I mean, this is a slide which all of us know, but I thought it will be better to, I mean, again, just to mention here. So whatever vaccine antigen that we give along with these adjuvants, and because this is the very important component that enhances the immunogenicity. So we see that even most of these vaccination gives us more immunity than a natural infection because of the presence of the adjuvants in the vaccine. And the right kind of adjuvant is very critical in deciding what kind of an immunity should be elicited, whether it should be a cell-mediated immunity predominantly or an antibody-mediated immunity predominantly. So whatever vaccine antigen that we give, this is a professional antigen presenting cell, that is the dendritic cell. We call them as professional antigen presenting cells because of the increased expression, the inherent or innate expression of the MHC class II antigens on their surface. So these vaccine antigens are taken up by the cell by endocytosis, and inside the from within the cell, it is presented through the MHC class II surface antigen. And this MHC class II interacts with the CD4 T cells to sensitize and stimulate a T cell receptor interaction, that those subgroup of T cells which will interact with this particular epitope that is being presented, they will get activated. And this activated T cell, when the same antigen is presented through a B cell receptor in a B cell, they interact and it leads to a T cell help, along with the right kind of cytokine that is being produced, like the IL-4 or the Th2 cytokines. This will lead to the proliferation of this T cell, and we get plasma cells and the memory B cell population, and leading to the a robust humoral immune response. In parallel, what we need is the antigen presentation through the MHC class I pathway to the CD8 positive cell. This also will be receiving help from the CD4 positive T cells and proliferation of the effector T cells and the CD8 memory cells. And this second component is very critical for a viral infection, for clearing the viral infection from the system, while the humoral immune response will be preventing the establishment of the infection. This T cell or the cell-mediated immune response is important in the clearing of the infection. Now, when we use a vaccine antigen, which is, okay, I'll come to that in the next slide. Now, before going to the details on that, let us just have a brief background on the herd immunity. So in a situation where there is no vaccination and there are large number of susceptible individual, whenever there is an infection happening, this can very freely get into the community. But when we have this, at least a partially immune population, in the chances of a person giving infection to the nearby person becomes significantly reduced. And when this increases beyond a threshold, even though there are few individuals in the community who are non-immune, then they are protected because of the herd effect of this particular immunity. And this is what we want to achieve in any vaccination program. It is impossible to get 100% immunity even by any kind of excellent vaccination schemes. It is it is impossible because of so many factors. But the beyond the threshold herd immunity, we get a protection because of the presence of a large number of immune individuals around a susceptible person. Now, this is the aim of the ongoing vaccination program. So one of the major criteria that decides what is the amount of herd immunity that would be anticipated to protect against a disease is essentially based on the route of transmission and the basic reproduction number of the particular the infection in question. So measles, which has a very high basic reproduction number, we need a very high herd immunity, like around 95%. And as you can see in the slide, as the basic reproduction number goes down, and also the herd immunity threshold that is required for protection also becomes reduced. So if you look at the Ebola or the influenza kind of basic reproduction number for the SARS-CoV-2 also, as we know, the major, still we can say that the major transmission route is the droplet transmission, even though there are questions about the airborne transmission of the SARS-CoV-2. We say that it is around 1 to 3 is the basic reproduction number. See, when we say about this basic reproduction number, we should also think about the original SARS-CoV-2 strain, not the mutant varieties. I'll come to that a little later. So we expect that around 50 to 60% of the herd immunity will give us a reasonable protection. So that is the kind of thing that we are trying to achieve. Now, the vaccines against SARS-CoV-2, the major target protein, as all of us know, it is a spike protein. And that is only because this is the major receptor binding protein. The interaction of this spike protein with the ACE2 is the one that is establishing the infection. And when we can block with an antibody to the spike protein, we can block the infection happening. So this is why we have selected for all the SARS-CoV-2 almost all the vaccine focuses on the spike protein. And there are also other reasons why this spike protein is the major focus. I'll come to that little later. And now this COVID-19 vaccine pipeline, if you look at all the new generation approaches have been tried in the COVID along with the conventional vaccine. So we have the mRNA vaccine, viral vector vaccine, whole inactivated vaccine like the Covaxin, and a number of companies where even the Sinovac is a whole virus inactivated. Then the Bharat Biotech, the Covaxin, then viral vectored vaccine, protein subunit vaccine, just like the hepatitis B vaccine. And then there is another company trying on the DNA vaccine. Then there are, as I mentioned earlier, there are some companies which started with the replication, replicating viral vector. But many of them have, stopped it subsequently. And as you can see, they are not working on this replicating viral vector. There may be many reasons to stop this, especially the side effects or the unwanted problems with having too much of antigen, spike protein antigen within the system. Now, the Covaxin, Dr. Harikrishnan has already mentioned a comparison on this Covaxin and Covishield. And this efficacy is, more or less same for both this Covaxin and Covishield. That is what is being claimed by the manufacturers. And now, coming to the mRNA vaccine, that is the Pfizer or the Moderna vaccine that is very widely used in the West. So this is the mechanism how this mRNA vaccine works. So we have this mRNA vaccine with a lipid coat, and this goes into the cytoplasm where this mRNA is released. And this mRNA is a functional mRNA which can get directly translated into a protein. So essentially, any functional mRNA should have a 5' cap that is a protection of the mRNA from getting degraded, and there will be a polyadenylation tail. And this message will give to the protein synthetic machinery that this is an mRNA which needs to be translated. And this will be undergoing the protein and the translation into proteins. The spike proteins will be produced within the cytoplasm. And a part of the proteins that is produced within the cytoplasm will get released outside in the immediate environment. And these spike protein that is released will be again endocytosed by the endocytic machinery. And once within the endosome, they will get degraded and they will get loaded into the MHC class 2 peptide. So this is an exogenous antigen for this matter. And this will get loaded into the this is loaded into the MSC class 2 peptide, which will be presented through the class 2 MSC molecule to the T helper cell, and this will trigger an antibody mediated immunity. So this is being done by the antigen presenting cell. In parallel, this mRNA vaccine, whatever proteins are produced endogenously within the system, part of it will get degraded by the proteasome machinery, and this will get loaded into the MHC class 1. And this MHC class 1 will be recognizing a corresponding CD8 positive T cell, and this, along with the help from the CD4 T cell, it will be augmenting a cell-mediated immune response. So this is very important, because when we use mRNA vaccine or a live vectored vaccine, where an endogenous, nucleic mRNA is being, it produces the protein, and both the arms of the immune system will be simultaneously stimulated. Suppose we are taking Covaxin primarily, it is an exogenous antigen, and there is no endogenous protein that is being produced. So this will be taken up by the endosome, and we will be getting a predominantly antibody mediated immunity, and this component will be significantly lacking in the inactivated vaccine. So, as I said earlier, the establishment of a viral infection is prevented by the antibody mediated immunity, but the clearance will be always better with a simultaneous effect of both arms of the immunity. And so we expect that these kind of vaccines, which produce endogenous proteins, will be in the long run, or giving us a long-term better protection with both the arms of the immune response. Now, what happens to this mRNA that we have given inside? So in the non-replicating kind of vectors that we use in the vaccine, there will be only, if there is only one mRNA going inside, that mRNA remains as one mRNA from which the protein is produced. So after that, see, any mRNA that is produced within the cell, there can be many types of proteins coded by this mRNA. Some of them are very violent proteins, like the cytokines and all that, which can, and many other proteins can be self-detrimental to the producing cell itself. So there are robust mechanisms for mRNA degradation within the cell. And even many of these mRNAs have their own signals for auto-degradation. So this maybe one of the mechanism is the decapping, where this is a protective cap, the guanosine cap at the 5' end of the mRNA that will be decapped. So once this is exposed, cellular protein degrading enzymes can, or the nucleic acid degrading enzymes can drastically degrade this by a 5', 3' decay mechanism. Or the other end of the mRNA can be chewed up by the RNA nucleases. And even within the tail of the mRNA, there are signals to decide its degradation. So none of these mRNAs will get accumulated within the system unless there are some inherent defects with the mRNA degradation system. And also, this may be one reason why they have stopped working on the replicating viral vectors, because they didn't want to have an accumulation of the protein within the system, like like we know about the protein accumulation and the kind of degenerative diseases that can happen. So they didn't want to have an exorbitant accumulation of the artificially injected protein into the system. That would be one reason why they have stopped working with the replicating viral vectors. But definitely the non-replicating viral vector, whatever mRNA is happening, and this is true with the natural infection also. Whenever this virus is infecting, whatever viral RNA molecules that is in the cytoplasm, they will get drastically degraded by the host machinery. And some of the viruses, successful viruses, can delay it significantly, so that they can produce sufficient number of progeny virions before these protein synthetic systems get degraded. So that is the inherent property of many of the viruses. Now, another new approach that is coming with the SARS-CoV-2 vaccination is like, as we know, the natural infection will trigger a uniform immunity in the upper and the lower tract. And we know that in the upper tract, it is mostly the IgA, and in the lower tract, along with the IgA, secreted IgA, the IgG also plays a major role in the protection. So when we do an intramuscular or intradermal vaccination, like what we do, the most of the protection will be because of the IgG, and that will be more effective in the lower tract. And so, as we know, the upper tract colonization by the virus will not be prevented because the IgA response is significantly poor for the intramuscular route of vaccination. And these two compartments, they are actually compartments itself, and like a blood-brain barrier kind of thing, that the crosstalk is, significantly less. Definitely, the injected vaccines will induce an IgA response, but it takes time, and even the quantum of that IgA response will be very less. And the intranasal vaccination that is being proposed, or the many companies are working on the intranasal vaccine, and the inoculation of this vaccine, just like a natural infection, it is expected that it will evoke both an IgA response as well as an IgG response, so that it will be more effective component of a vaccine. So what happens is, whenever we give an intranasal vaccination, it will trigger the B cells which are homing the mucosal surfaces. B cells got certain addition molecules on their surface, and especially the IgA producing B cells will be adhering to the mucosal tissues, and those will be the one that will be getting stimulated by the antigen presenting cells in the mucosal vaccination, and they will produce antibody, IgA antibody, that will be at the dimeric kind of functional IgA molecule. IgA antibody is a dimer, and it has significantly more neutralization potential for the vaccine, the virus. And recent studies have shown that this mucosal immunity, even though the systemically we can detect monomeric IgA molecule, the dimeric IgA molecule is the one that is very important in the SARS-CoV-2 infection, that can neutralize the virus. And also, in a natural infection, in less than 7 days, this IgA, the dimeric IgA level in the mucosal, especially they have done with the bronchoalveolar lavages, and they have seen that significant amount of this dimeric IgA can be detected in the bronchoalveolar lavage fluids. And also, this IgA is a very versatile molecule that can protect the mucosa. There are two isotopes, isotypes A1 and A2, and also a lot of glycosylation and variant forms, so which will enhance the spectrum of activity of this IgA molecule. So now the more and more studies are telling that this IgA component is a significant requirement for the prevention of initial colonization and protection of the future infection, apart from the systemic vaccination. Now, one of the major worries that we have is about the, especially since we know that the SARS-CoV-1 and the MERS viruses have this antibody-dependent enhancement mechanisms operating. So we are worried about this vaccine. And even recently, there have been a lot of WhatsApp newses or the comments from virologists, that is, or so-called, maybe the I think most of them are spurious newses, or the messages that is coming up, that it can induce an ADE response. So far with the SARS-CoV-2, these are the common mechanisms of antibody-dependent enhancement. There are two mechanisms proposed. One is, whenever there is a low level of antibody or the non-neutralizing antibody present in the system, it can facilitate, it can bind with the spike protein, and it can facilitate the infection of the macrophage through the Fc gamma receptor that is present in the macrophage. So once the virus is, even in normal case, there will be some amount of, the macrophage can phagocytose this viral particle, but this will enhance significantly the entry of the virus into the macrophage. And this is very important, that this will work only for macrophage tropic viruses, where this virus, once get inside, can replicate within the macrophage and produce large amount of viruses. And interestingly, for SARS-CoV-2, they have not seen that it has got a significant macrophage tropism. It can replicate within the macrophages in significant number. So this particular mode of antibody-dependent enhancement is not thought to be operating in case of SARS-CoV-2. Now, Coming to the second mode of action is the immune complex formation. When there is sufficient level of antibody that is present, it can form immune complexes. This is one of the mechanisms that was proposed for the RSV and the measles ADE mechanisms. And whenever there is immune complex that is being formed, the free end of the antibody can bind into the macrophages, and so in the milieu there will be accumulation of more neutrophils or macrophages, and there can be secretion of pro-inflammatory cytokines, parallelly complement cascade activation, and this can enhance the pathology. So maybe this even they call this as the enhanced respiratory disease, ERD, and along with this ADE mechanism, both can enhance the severity of the disease. But this mode of mechanism may operate with the SARS-CoV-2. We don't know. There are no proofs so far. Even animal studies have not shown, primate studies have not shown that there is an antibody-dependent enhancement mechanism acting in case of SARS-CoV-2. And we also know that we see a lot of reinfection cases now, and we don't see any enhanced severity because of a prior vaccination or a prior infection. So inherently, we don't think that these two mechanisms operate in case of SARS-CoV-2 infections. But there is a possibility of a second mode of antibody-dependent enhancement that may happen, but we need to have more studies. And also, in this context, we should think about the nasal vaccination or any other vaccination scheme which will enhance more amount of IgA response, because the significant amount of IgA cannot induce an antibody-dependent enhancement, because this receptor is a gamma receptor which will bind only to the IgG molecule, not to the IgA. So this maybe the significantly enhanced level of IgA in the lung or in the mucosal surface will prevent the preferential binding of IgA, will reduce the binding of the IgG, and it will reduce the chance for an antibody-dependent enhancement. So this is also another important criteria why we should focus more on the mucosal immune component of this. So these are some of the possibilities proposed by which the SARS-CoV-2 infection can cause an antibody-dependent enhancement. But in all these cases, I don't want to take more time in explaining this slide, but in all these cases, the lower level of antibody is the one that is proposed as that will precipitate an antibody-dependent enhancement. So that is one thing that we need to wait and see, because now what we are seeing, all these reinfection cases or all the infection cases that is after vaccination, is in the scenario of a high antibody titer in the system. And as with the vaccine immunity or the infection immunity wanes, and subsequently when an infection happens, what would happen? That is one thing that we need to look forward to. But the animal studies shows that even at a very low amount of non-neutralizing antibody presence, there is no chance of a antibody-dependent enhancement. Now, this is another interesting aspect. Before conclusion, I want to show you a few slides. This is a paper which was uploaded on May 27th. That was yesterday. This is a very important aspect that we need to look into, which says that the SARS-CoV-2 variant 617.2 is having reduced sensitivity to the monoclonal antibodies and sera from convalescent and vaccinated individuals. I wanted to tell about this because of some particular reason. And this is the 617 mutant, which has an L452R and E484Q in the receptor binding domain. And there are two variants for this 617. This is 617.1 and 617.2. And this paper is talking about the 617.2. And 617.1 was the earlier double mutant that was identified in Delhi and Maharashtra and most of northern India. And this is the mutation that is the typical for the 617.1. But when it comes to 617.2, instead of this E484Q, we get a mutation T478K. And this is in the receptor binding domain, and this is the place where the antibody has to bind and neutralize. And any amino acid change in this position will affect the affinity of the interaction and the neutralization ability. And there is also another variant, 617.3, but that is, it's not a major variant because the amino acid change is not falling in the receptor binding domain. Now, when we look at this particular variant, this is one of the assays very widely used, and this is a representative of the assays that we are doing in our institute at RGCB. And this is a pseudo-virion based assay. So what we do is, we generate, because for handling the infectious SARS-CoV-2, we need a BSL-3 facility, and at present we don't have it. And world over, this is a simplified assay where we can look at the SARS-CoV-2 spike protein ACE2 interaction. So whenever there is in the pseudo-virion, what we do is we take a vesicular stomatitis virus, and instead of its envelope protein, we substitute it with the envelope protein or the spike protein of the SARS-CoV-2. So essentially, it is a virus which can be handled in a BSL-2 facility because the pathogenic SARS-CoV-2 genome is removed, and only the spike protein is incorporated into a vesicular stomatitis virus genome, and that is a pathogen that can be handled in a BSL-2 facility. And what happens is, whenever this spike protein and ACE2 interacts, this VSV, which has some reporter gene encoded inside, will go inside. For example, whatever system what we are using is a fluorescent based system. We see that all these fluorescent colors shows the cells which are infected. And what we use is an ACE2 expressing cell line. And whenever this virus is infecting or the pseudovirus is infecting and delivering this GFP genome inside, it will fluoresce. And whenever there is an antibody neutralizing this, we will see that there is a reduction in the fluorescence. This is a very straightforward assay. And this is the assay mostly used across the world for evaluating the neutralizing efficiency of any antibody, even whether it is a monoclonal antibody or whether it is an antibody from a patient. And this is the assay that we have developed. The same kind of assay was used by the publishers of this earlier paper. And the most important and interesting thing what they have seen is, whenever they have used the pseudovirions representing this 617.2 or the African variant, there is significant loss of neutralization ability. And you can see their sample size is very less, like they could only collect samples from 12 individuals, but they see that, you should note that only one person out of the 12 individuals could neutralize the infection by 617.2. And this is another important observation. We have been sequencing the SARS-CoV-2 strain circulating in Kerala. We are getting samples from Trivandrum, Pathanamthitta, Kollam, Alleppey, and we see that more than 90% of the strains that is currently circulating in Kerala belongs to the 617.2. And this is the vaccine we call Covishield. And the same way, this is another vaccine that we are using is the Covaxin. And we don't have any studies on Covaxin, but this is the Covishield that we had used earlier. And this is the 617.2. And most of the infections that we see, we think that, and in this cohort of samples or in this group of samples that we have analyzed, there are people who are getting infection for the first time. There are people who are getting infection after 1 dose of vaccine, 2 doses of vaccine. There are people who are reinfected. And all these people are showing, this is the 452 site mutation, and this is the K mutation. This combination is indicating it is 617.2. So we are seeing a significant number of breakthrough infections. And this is one major issue that we need to address in the future about the vaccination. So with this, I will stop and we can go into the discussion. Thank you.
Thank you, sir. Thank you so much for that very exhaustive discussion on the virology part of vaccines. I will get back to you shortly because we have a lot of questions in the chat box, specifically regarding various aspects of the molecular virology of the vaccine and antibody-dependent enhancement, and especially the WhatsApp messages which you alluded to earlier. But meantime, let me quickly go over to Dr. Sitara from district administration side.
Sir, one
yes.
minute, sir. Srinivas sir, can you stop your share, sir, please?
Yeah, sure. I'm just, yes.
Yeah. So could we quickly go over to Dr. Sitara and get her view about the current status in our district, and are we facing shortages, and what is the outlook for the next let's say couple of months regarding where our vaccination program is going to be? So over to you, madam.
Thank you, sir. ഞാൻ മുമ്പേ എല്ലാം പറഞ്ഞു കഴിഞ്ഞൊന്നും പറയാനില്ല.
ഒന്നുകൂടെ പറഞ്ഞു, കുഴപ്പമില്ല.
So നമ്മൾ വാക്സിനേഷൻ സ്റ്റാർട്ട് ചെയ്തത് 16th ജാനുവരിയിലാണ്. നമ്മൾക്ക് അന്ന് ഹെൽത്ത് കെയർ വർക്കർ അന്ന് രജിസ്റ്റർ ചെയ്ത് 34,260 ആയിരുന്നു. അവര് നമ്മൾ ഫസ്റ്റ് ഡോസ് വാക്സിനേറ്റഡ് ചെയ്തു. അത് കഴിഞ്ഞ് സെക്കൻഡ് ഡോസ് എടുത്തത് 27,268 ആണ്. ഫ്രണ്ട് ലൈൻ വർക്കേഴ്സ് നമ്മൾ സ്റ്റാർട്ട് ചെയ്തത് February 22 ആണ്. 34,731 രജിസ്റ്റേർഡ് ആയിരുന്നു. അവർക്കത് നമ്മൾ അന്ന് കൊടുത്തിരുന്നു. സെക്കൻഡ് ഡോസ് അവരിൽ സെക്കൻഡ് ഡോസ് എടുത്തത് 23,878 ആണ്. എബോവ് 60 നമ്മുടെ ടാർഗറ്റ് പോപ്പുലേഷൻ 4,10,000 ആയിരുന്നു. വാക്സിനേറ്റഡ് 3,55,417. സെക്കൻഡ് ഡോസ് എടുത്തത് 66,631 രജിസ്റ്റേർഡ് ആയിരുന്നു. അവർക്കത് നമ്മൾ അന്ന് കൊടുത്തിരുന്നു. സെക്കൻഡ് ഡോസ് അവരിൽ സെക്കൻഡ് ഡോസ് എടുത്തത് 23,000.
Okay, madam. ചെറിയൊരു എക്കോ ഉണ്ടായിരുന്നു, കുഴപ്പമില്ല. Madam, one more thing. Are our private hospitals starting to offer vaccines, and in Kottayam, what about the supply of Sputnik and other vaccines? നമ്മുടെ private sector, is there any plan like that?
Sputnik ഇല്ല. കോവിഷീൽഡ് ആണ്. അത് 2 ഹോസ്പിറ്റലാണ് ഇപ്പൊ സ്റ്റാർട്ട് ചെയ്യാൻ പെർമിഷൻ ഉള്ളത്. ചെത്തിപ്പുഴ ഹോസ്പിറ്റലിൽ 3,000 വാക്സിൻ അവർ പർച്ചേസ് ചെയ്തിട്ടുണ്ട്. കിംസ് മൺഡേ സ്റ്റാർട്ട് ചെയ്യും.
ഓക്കെ, അതും കോവിഷീൽഡ് തന്നെയാണ് മാഡം? കിംസിനും
കോവിഷീൽഡ് തന്നെയാണ്.
ഓക്കെ. അപ്പൊ മറ്റ് വാക്സിനുകൾ വരാൻ സാധ്യത പ്രൈവറ്റ് ഹോസ്പിറ്റൽസ് എങ്ങനെയാണ് മാഡം? ബിക്കോസ് എനിക്ക്
കോവാക്സിന് ചാൻസ് ഉണ്ട്. നമ്മൾ അപ്പോളോ ഹോസ്പിറ്റലിൽ കോവാക്സിൻ സ്റ്റാർട്ട് ചെയ്തിട്ടുണ്ട്. ഇവിടെയും കോവാക്സിൻ തന്നെ അവർ എടുക്കുന്നുണ്ട്. പിന്നെ വെൽഫാസ്റ്റ് ഹോസ്പിറ്റൽ സ്റ്റാർട്ട് ചെയ്യാൻ പോകുന്നുണ്ട്.
ഓക്കെ, നമ്മുടെ ഈ DHSന്റെ ഇൻഫർമേഷൻ അനുസരിച്ച് ഹെൽത്ത് കെയർ വർക്കേഴ്സിൽ ഒരു 20% ഷോർട്ടേജ് ഇപ്പോഴും ഉണ്ട്, വാക്സിനേഷൻ ഗ്യാപ്പ് ഉണ്ട്. ആ ഗ്യാപ്പ് നമ്മൾ ഇതിന്റെ ഷോർട്ട് ടേം അത് കവർ ചെയ്യാനായിട്ട് ഇനി മാഡം എത്ര വീക്സ് ഫോർസ് ചെയ്യുന്നു? 2 weeks or 4 weeks?
4 weeks വാക്സിൻ വരുന്നതനുസരിച്ച് 1 month കംപ്ലീറ്റ് ചെയ്യാന്നാണ് വിചാരിക്കുന്നത്.
Okay, madam, thank you so much for sharing your experience with us regarding our plans for the next month. Now let me go over to our own community medicine department, Dr. Anupa and Dr. Anju, to share with us our vaccine experience and resistance, if any, and other issues, adverse effects which you have come across, which have stood in the way of vaccination. Did we have any severe? Let me start off with Dr. Anupa. Madam, in your experience, did you have any severe anaphylactic reactions or something which became dangerous or required treatment?
Thank you, sir. We had actually looked into the AEFI immediately after the first dose. So what the most common AEFI found obviously was fever. Around 60%, more than 60% of people had fever, and along with that body ache. These were the most common symptoms. And only 1% of the population did not have any symptoms. Like 99% had some kind of an adverse reaction. But fortunately, it all could be managed with up to 5 or 6 doses of paracetamol. Very few required steroids and hospitalization. The other symptoms which were there were nausea and vomiting, abdominal symptoms, and one or two cases of insomnia was also there for following vaccination, and anosmia also. Specifically, 3-4 days people were complaining of sleeplessness. So this is the profile of AEFI that we found. Then regarding what the other thing is, like sir was talking about breakthrough infection. So we were been collecting data from health workers, and Dr. Ronnie from our department, we did a preliminary crude analysis, and we looked into 3 months data of health workers who got infected, and we found that there is, if you take 100 people, there are around 2 to 3% who got this infection. That is, people who got all the people who got vaccinated, vaccinated we defined as 2 weeks after second dose, 2 completed weeks after second dose.
Madam, ഒരു കാര്യം പറഞ്ഞോട്ടെ, ഈ പുതിയ മ്യൂട്ടന്റ് we started seeing it only after April.
Yes, so this is mostly data after April, sir. Not April, yeah, March, April. We can't say which is.
Yeah, I
know
think
what you're trying to, find out whether it is because of the new mutant that we are getting these infections. Maybe, I don't know. We have to look into it. Month-wise, we have to look specifically into it.
But I think the numbers might be slightly higher because, Krishna Kumar from ID and myself, both of us were also looking into it. And we found that, a lot of people who had healthcare workers who had taken the vaccine have actually developed infection. Though it may be asymptomatic, none of them went on to develop a very severe illness per se, but still, as far as the illness is concerned, diagnosis is concerned, they became positive. Okay, let me quickly go. Yes, please go on.
No. Any other questions?
I was just going to Dr. Anju and trying to ask, do people actually come and tell you all their medication history and allergy history? Do you actually turn away people because they say, I am having, let us say, penicillin allergy or a food allergy? What happens there?
No, sir. We have given more than 500 doses with high risk consent.
Okay.
Those with allergy, first we will tell it is as per guidelines, it is contraindicated. But if they opt for it, we will give with high risk consent.
Okay, that is, do you make them sign it, give it to you in writing that
with informed consent they will write, and we will administer. Within 30 minutes, we have not ever noticed any acute reaction following in vaccination.
What about people with critical illness? Let us say people with let us say CKD or heart failure. Do you feel that if they are decompensated or if they are acutely symptomatic, do you turn them away? What is the protocol?
Actually, not such a severely sick patient have not come. Those with the chronic conditions, we will give.
Okay. Thank you, Dr. Anju, for that input. Thank you, Dr. Anup also.
Sir, we want to tell you something. We got an increased number of people with allergies reactions because from the periphery they refer to medical college, because we are a tertiary care center and we are better equipped in managing anaphylaxis, if any. But fortunately, we have not had any anaphylaxis. We had a few episodes of vasovagal syncope and people fainting because of hypoglycemia and all. But fortunately, we have not had. And one group is people who come and say, I have an allergy to this beef, I have allergy to this drug. But we have vaccinated almost, none have been turned away. We have taken a high risk consent, preferably written in their own writing, and we have given vaccine. And people on chronic medications, especially people, see in Kottayam, we have a very educated, informed lot. So they come with their medication, they say, I've consulted my cardiologist and they've given permission. So the job has been easy for us. So we have not faced any such thing so far.
Yeah, I too feel that it is better to provide these people with vaccine rather than turn them away. What sometimes happens in the periphery is that most people might not even be referred. That is a problem. You might be just turned away, saying that you are not a vaccine candidate. If they refer the patient to us, obviously we can give it under a high risk consent. But sometimes they don't even get that opportunity, and a lot of people just miss out. Anyway, it is good to hear that a lot of people are receiving it under at least under high risk, considering the benefit versus risk. Okay, so thank you, Dr. Anuba, and thank you, Dr. Anju, for sharing that with us. Now I want to get back to Srikumar sir regarding a few questions we have from our chat box, and I would want all of you to have to just type in your doubts in the chat box so that I can just forward those questions to the appropriate panelists and get their answers. Okay, so the first one which I need to ask you is, sir, why does the natural infection, why does it not produce such a robust immunity, and why do we expect vaccine to give us the immunity which the natural infection does not?
See, the major difference is in a vaccine, we have the adjuvants present, and that too, all the modern vaccines have got very high efficiency, tailor-made adjuvants, which can either evoke a Th1 immune response or a Th2 immune response. So conventionally we were using alum or aluminum hydroxide and all that, but later on now there are so many modifications in the adjuvants that has come up, and that is one of the major component that evokes an immune response. So in a natural infection, it is only the inherent capacity of that organism or the virus or bacteria, whatever it is. And it's only that inherent capacity of that organism that works. And in case of vaccine, we are purposefully augmenting the immune response. That is why these vaccines are working or giving a more robust immune response.
Okay, thank you, sir. Thank you. There was another question on whether a patient who's taking pulse steroids need to stop that pulse steroids, and if so, for how long before taking the vaccine. I will give you my take on that before I pass it on to Anupa madam and Anju. My personal take on that would be to, if the pulse steroids are essential for your therapy, I think that should not be stopped, and then you can take the vaccine. Granted, your vaccine efficacy might be slightly lesser than normal, but still, if your pulse therapy is life sustaining, then we cannot get rid of that. What is your opinion, Dr. Anupa?
I don't have any expertise or experience to comment on that. So,
if such a person turns up at your vaccination point, will you send the patient away, or will you
No. Usually you ask them to consult their treating doctor. We have had cases referred specifically after stopping certain drugs. So we don't. It's not usually we don't take it as our call, but we definitely take a call when it comes to rabies vaccine. So, I don't think anybody has put up that question, but when people come with animal bites, we definitely give vaccine, and the preference is for the rabies vaccine over Covishield. So the recommended duration of the gap between two vaccines is 2 weeks. So we manage accordingly.
Srikumar sir, is there any problem? I mean, taking long-term steroids.
എനിക്ക് മനസ്സിലാവാത്ത ഒരു ടെർമിനോളജി ആണെന്ന് പറഞ്ഞിട്ട് പൾസ് സ്റ്റീറോയിഡ് എന്ന് പറയുമ്പോൾ എന്താണെന്ന് ഉദ്ദേശിക്കുന്നത്? ഒരു ലോങ് കോഴ്സ് ആണെന്ന് ഉദ്ദേശിക്കുന്നത്, ഷോർട്ട് കോഴ്സ് നിർത്തിയിട്ട് വീണ്ടും എടുക്കുന്നത്?
അതാണ് പൾസ് എന്ന് പറയുന്നത് തന്നെ ഷോർട്ട് കോഴ്സ് ആണ് ഉദ്ദേശിക്കുന്നത്.
Definitely it is a short course, it should not affect any.
അത് യൂഷ്വലി ഒരു 1 gram 1 gram per day methotrexate equivalent 3 to 5 days കൊടുക്കുന്നതാണ് യൂഷ്വലി നമ്മൾ pulse എന്ന് പറയുന്നത്.
Okay. So
what about long-term steroid therapy? Suppose
long-term steroid therapy, I don't think it will lead to a very drastic immunosuppression for a vaccine antigen. നമ്മൾ നേരത്തെ പറഞ്ഞ natural infection അകത്തുള്ള ഒരു situation അല്ല ഒരു വാക്സിന്റെ കേസിൽ വരുന്നത്. We have the strong adjuvants that is working in that. So സാറ് പറഞ്ഞ മാതിരി it might reduce the efficacy little bit, but not completely, definitely. So നേരത്തെ സാർ പറഞ്ഞ മാതിരി ഒരു ലൈഫ് സസ്റ്റൈനിങ് സിറ്റുവേഷനിൽ കൊടുത്തുകൊണ്ടിരിക്കുന്ന ഒരു സ്റ്റീറോയിഡ് ട്രീറ്റ്മെന്റിനെ സപ്പോർട്ട് ചെയ്തൊരു വാക്സിനേഷൻ കൊടുക്കണമെങ്കിൽ ഡെഫിനറ്റ്ലി ആ സ്റ്റീറോയിഡ് നിർത്താതെ തന്നെ കൊടുക്കാമെന്ന് എനിക്ക് തോന്നുന്നു.
Sir, another question, that too regarding just as continuation of the previous question, natural infection vaccine efficacy karyam parayan. How long actually right now do we know the vaccine efficacy lasts? Obviously all vaccines are new, we don't have too much long term data, but are there any models which tell us okay
ഒന്നാമത്തെ SARS-CoV-1 കേസ് വെച്ചിട്ടുള്ള ഒരു സ്റ്റഡി ചൈനയിൽ നിന്ന് നേരത്തെ കുറച്ചാണ് മുമ്പ് വന്നതിനകത്ത് they could detect the antibody till 2 years. അപ്പം ഇതിന്റെ കേസിൽ നമുക്ക് അങ്ങനെ പറയാൻ പറ്റുന്നില്ല, ബിക്കോസ് SARS-CoV-2 കേസിൽ ഒരു പ്രത്യേകത ഉള്ളത്, the infection never sustained, there were no mutant viruses coming up, it was only the initial exposure to that individual. Subsequently there was no virus circulating in the community. But in the case, the problem is there are mutants coming up. So whether the original, even now, the original vaccine that we have taken is not giving us complete protection, even though in the second infection there is significant reduction in the severity. So that is the major benefit that we are getting out of the vaccination. But the people are still susceptible in spite of the presence of the antibody. So how long it is പിന്നെ എത്ര നാള് ഇവർക്ക് ഒരു സിവിയർ ഡിസീസ് വരാതെ നിൽക്കുന്നു എന്നുള്ളതായിരിക്കും ചിലപ്പോൾ കുറച്ചും കൂടെ ഒരു ഇതായിട്ട് വരാൻ പോകുന്നു.
Do you feel that in future perhaps there might be a role for yearly booster doses like influenza ക്ക് ഇപ്പോ ഏകദേശം ഒരു ഇതാണല്ലോ എല്ലാ വർഷവും ഒരു ഇൻഫ്ലുവൻസ വാക്സിൻ എടുക്കാന്ന് പറയുന്നത്.
ഒരു അടുത്തൊരു few yearsലെങ്കിലും definitely there will be a role. മാത്രമല്ല, maybe we need to have a different, we need to have a modified vaccine rather than using the original Wuhan strain. We may have to have a vaccine with a new mutant variety of the virus.
I understand several companies are already working on that, isn't it?
Yes. See, that is one of the major advantage of this kind of vaccines. Suppose there is a mutation, just like influenza vaccine, making a new vaccine becomes very easy. You just simply do a site-directed mutagenesis in the parent clone and make a new vaccine. So it's very easy. So like a site-directed mutagenesis, you can do maybe in 2 days or 3 days, and you can make a parent construct and you can start producing vaccine from that. So that becomes very fast.
Okay, thank you, sir. A couple of questions to Dr. Anupa. Yeah, you were trying to say something. You can just add on to the answer.
What I was saying, COVID will become like influenza after a few years. The virus will take some time to settle. Till then, it will spring surprises. So we will have every time it surprises. We have to be on. So it will reach a point when the virus gets stabilized and it will attain a seasonality. Then we will systematically collect data and produce vaccines like we do for influenza now. So
we certainly hope so, but that has not been our experience with SARS and MERS, which were both very aggressive strains, and then we had a burnout. Okay, at least as far as H5N1 and H1N1 are concerned, that what you said happened. They just know nowadays we do not know whether a patient who's having a common cold is actually having H1N1 or H5N1 because we don't even check. A couple of more questions to you, Dr. Anupa. First of all, I just showed in my presentation about thrombotic complications following Covishield. Have you, in our experience here, seen any patient with thrombotic complications at all?
See, we sit in the clinic and we are more looking at immediate AFIs. So from the department, we have not looked into thrombotic episodes, and I think with a lot of coronary artery disease in the background, it's very difficult. Even if there is an increase, it will be a very slight increase, very, very difficult to make out. That's what I feel. But we have not come across any increased numbers.
Right. Perhaps a very careful history has to be taken in people who are presenting with cortical venous sinus thrombosis or DVT or pulmonary embolism or such. A history of COVID vaccination perhaps needs to be taken also. One more
Sitara
question.
has something to say. Sitara has something to say.
Yeah, sir. നമുക്ക് AFI കോട്ടയം ജില്ലയിൽ ആകെ റിപ്പോർട്ട് ചെയ്ത 190 കേസസ് ആയിരുന്നു. അതിൽ 5 സീരിയസ് കേസസ്, ഒരു MI, 6 ഡെത്ത് വാക്സിൻ റിലേറ്റഡ് അല്ല എന്ന് പറഞ്ഞു. പക്ഷെങ്കിൽ പോസ്റ്റ്മോർട്ടം ഒക്ലൂസീവ് കൊറോണറി ആർട്ടറി ഡിസീസ് എന്നാണ് വന്നത്.
Anyway, it is very difficult to prove causal role. അപ്പൊ ഇവർക്കെല്ലാം കോവിഷീൽഡ് ആയിരുന്നല്ലോ മാഡം?
എല്ലാവർക്കും കോവിഷീൽഡ് ആയിരുന്നു. കോവാക്സിന് നമുക്കൊന്നും റിപ്പോർട്ട് ചെയ്തിട്ടില്ല ഇതുവരെ.
Two things, sir. One, it is only a slight increase, if at all. If there are increased episodes, only a slight increase. Second thing is that the infection itself can cause such episodes, no? So it may be a little difficult to make out whether the vaccine is causing it or the infection is causing it. So I don't think we are yet reached the time to comment on, make any assumptions like that.
One more question to Sitara madam, while you are here, madam. You are also the RCHMO, so this pertains to that. What is the likelihood of vaccination being offered to pregnant women anytime soon? Does the government have any plan for that? because this is a big population whom we have left unvaccinated, and nowadays we are seeing a lot of patients, COVID positive patients in pregnancy. So is there any specific?
നമുക്കൊന്നും ഇല്ല,
ഇല്ല,
ഇപ്പൊ ഇതുവരെ ഒന്നും ഇല്ല. നമുക്ക് 2 കേസ് ഉണ്ടായത് ഒരു നേഴ്സ് ആണ്, രണ്ടും കാരിത്താസ് ഹോസ്പിറ്റലിൽ നിന്നാണ് റിപ്പോർട്ട് ചെയ്തത്. വാക്സിൻ കഴിഞ്ഞിട്ട് അബോർഷൻ ഉണ്ടായി, അത് റിപ്പോർട്ട് ചെയ്തു. പക്ഷെ ഒരെണ്ണം കോവിഡ് പോസിറ്റീവ് ആയിരുന്നു. അതുകൊണ്ട് നമുക്ക് അതിന്റെ കൊണ്ടാകും എന്ന് പറയാൻ പറ്റത്തില്ല. വേറെ 2 കേസാണ്, പക്ഷെ അതൊന്നും നമ്മൾ ഇതാക്കിയിട്ടില്ല.
Okay. Another question: what about people planning their family? Actually, is there any logic or sense in asking them to defer conception or something like that in people who are planning to take vaccine? അങ്ങനെ എന്തെങ്കിലും ഗൈഡ് ലൈനോ അതെല്ലാം ഉണ്ടോ? അറ്റ്ലീസ്റ്റ്
നമുക്ക് ഫസ്റ്റ് ഉണ്ടായിരുന്നു, ഫസ്റ്റ് ഗൈഡ് ലൈൻ പ്ലാനിങ് ഫോർ പ്രഗ്നൻസി അവർ എടുക്കണ്ടെന്നായിരുന്നു ആദ്യം പറഞ്ഞിരുന്നത്. അതനുസരിച്ച് നമ്മൾ അവർക്ക് കൊടുത്തിരുന്നില്ല.
അതിപ്പോ ഇൻ ഫോഴ്സ് അല്ലാന്നാണോ മാഡം പറയുന്നത്?
ഇല്ല, ഇപ്പോഴും അത് വന്നിട്ടില്ല. ഇപ്പം കോൺട്രാൻഡിക്കേഷൻ പറഞ്ഞേക്കുന്നത് പ്രഗ്നൻസിയും റിയാക്ഷൻ അനഫിലാക്റ്റിക് റിയാക്ഷൻസ് അതാണ് പറഞ്ഞേക്കുന്നത്, 2 എണ്ണം. പിന്നെ റിലേറ്റീവ് കോംപ്ലിക്കേഷൻസും ബാക്കി.
Lactation is a contraindication. No, it has also been removed. Okay, thank you, madam. Thank you. Now, one more question to Dr. Anuva. Madam, what about giving other vaccines? There is a specific question about people receiving the 3rd dose of hepatitis B vaccine. The timing coincides with the time for the 1st dose. So, can you take these vaccines together, or do you need to space them out? If so, what is the gap? Because hepatitis B, after all, is only a subunit vaccine. So, do you need to space it out, or what is the present status?
Recommendation is a gap of 2 weeks between any vaccine and Covishield. So every time a case comes, we do a risk analysis. Like if it is rabies, we have to give. If it is some vaccine which we can postpone for a month, we do it accordingly. So it's a probably a case by case basis, but 2 weeks gap is recommended. And Anshu, you have any comments on that?
But as per recommendation, after hepatitis 3rd dose, after 2 weeks, we can take Covishield.
So only 2 weeks gap is recommended, is it not?
Minimum 2 weeks is the recommended.
Okay. Yeah, thank you. One more question. That is I think I'll answer it myself. It's a very interesting question. Why don't we give tadalafil tablet along with Covishield vaccine to prevent thrombosis complications? Certainly a very innovative idea to prevent thrombosis. Tadalafil obviously is a phosphatase 5 inhibitor having multiple other uses. Right. So the problem with Covishield is that after vaccination, most of the thrombotic events have been related to a generation of antibodies against platelet factor 4. I think Srikumar sir can perhaps elaborate on that. And so that antibody production and subsequent platelet activation and thrombosis is not going to be retarded by giving the patient a phosphatase 5 inhibitor. So I don't think that is a realistic solution to prevent thrombotic complications. Sir, one more question I'll just add on before you take up that question on platelet factor 4. That is, somebody has been asking about the furin cleavage site, which is different from SARS-CoV-1 and SARS-CoV-2. Just a few words about that too.
This furin cleavage site, the question came because there was a comment by David Baltimore that this furin cleavage, so that was mentioned in that comment itself. So like it might be indicating that this is a synthetic virus, lab-made virus or something like that. But interestingly, this furin cleavage site is seen in other coronaviruses also, like feline coronaviruses, beta coronavirus family. There are a number of viruses in that. This furin cleavage site is seen in those viruses. So it is not unique to SARS-CoV-2, but as a human pathogen, maybe it is unique because it is not seen in SARS-CoV-1 or MERS-CoV. So that may be why people are more curious about this furin. But in animal coronaviruses, it is seen. In bat coronaviruses, it is seen. So it's in that family of beta coronaviruses. This is seen in many viruses. So there is no unusual thing about the furin cleavage. And second thing, that the platelet factor 4, I'm not been very, very sure about that, but I read somewhere maybe it has some genetic component or some MHC component associated with that or something. I've read somewhere, but I'm not very clear about it.
Sir, what about this mixing and matching? People usually, one of the very most common questions which is asked is, can I take a Covaxin after taking a Covishield or vice versa?
If you give me a chance, I will do that.
Okay, there is now new data accumulating that what's so-called the prime boost regimen, that is prime with the Oxford vaccine and then take some preferably an mRNA vaccine. It is going to give you optimal immunity.
Well, essentially, the immunogenic domain that we are speaking about is the spike protein, which is present in both the vaccines, and all other added things are only to boost the immune response, and that is anyway required for both these vaccines. So, I mean, whatever immune cells which are sensitized by the first vaccine will be the same one that will be resensitized or triggered by the booster vaccination. So, technically speaking, there is no harm in mixing and matching because we are not injecting them simultaneously. We are injecting them after a gap of a few months or a few weeks. Then, but the problem is as per the regulatory approvals. So whatever clinical trials have been done is only for the 2 consecutive doses of a particular type of vaccine. So a practitioner will not be in a position to recommend another vaccine because of the regulatory constraints. But scientifically or technically, there is no harm.
Thank you, sir. There are many questions about pregnancy and vaccination. We asked our panelists that still there are some doubts regarding that, whether some guidelines really advocate vaccination. Yes, they do. As I said, the problem is only with Covishield and Covaxin because, as I said, as it has been quoted in the question itself, American College of ONG, they have very clear guidelines saying that pregnant patients should not be denied the COVID vaccine, and the common COVID vaccine there is obviously the mRNA vaccine, both Pfizer as well as Moderna vaccine. So there is no harm, and they actually encourage pregnant patients to take it because I just showed you that paper from NEJM where they looked at the difference. And they found that, the difference in stillbirth, prematurity, all those things not different between the control group and the people who took the vaccine. So pregnancy need not be a contraindication for COVID vaccines, at least as far as the mRNA vaccines are concerned. Regarding the Covishield and Covaxin, we have absolutely no data to comment. Covishield, because the patients have not been enrolled in the trials, as sir was talking about the regulatory approval. So it might not be possible to get regulatory approval for use in pregnancy and lactation.
See, are there other vaccines that is being given in pregnancy?
Yes, sir. In the US, they use the mRNA vaccines. So
no, I mean, in regular case, not this COVID vaccine, but there are other vaccines which can be given during pregnancy. So these vaccines do not produce any extra side effects than the other vaccines. So if a pregnant individual can tolerate the other vaccine, definitely these vaccines also should be tolerated by them. And none of these vaccines are live virus vaccines. There is no replicating virus introduced into the system. Only the immunogenic component is being introduced. And technically, again, technically, there is, no issue should be there with the use of these vaccines. But again, this question of approval is always an issue. And maybe there should be some initiative to do a small-scale clinical trial with the pregnant individuals, or at least some of those initiatives from maybe ICMR will do it, or other agencies will do it, but that is an essential need for a community.
Okay, so one more thing regarding the and I'll put that question to sir first, and then I'll come back to Sitara madam. But is that the dose? Is the interval between the doses? Both for Covishield as well as Covaxin. As far as Covishield, the dose the interval went from 4 weeks to 8 weeks, and now it is up to 12 weeks. So, sir, what is the difference in efficacy between there are obviously reasons for vaccinating soon and reasons for giving a good gap between the vaccines. So what are the points for and against for as far as Covishield at least is concerned?
See, Covishield, as I said, it will stimulate both the arms of the immune system, both the cell-mediated and the antibody-mediated immune system in a very robust way, because there is an intracellular protein component that is being produced. So we can delay the vaccination because there is a significant cell-mediated immune response component happening. So that is why they are recommending maybe we can reduce even up to increase up to 12 weeks. 120 days. We can increase 4 months. So we can increase delay the Covishield second dose. And many times what happens is delaying is in a way good, because there is an element of immune system maturation after the primary vaccination. And only those highly reactive or highly specific T cells will be remaining in the long run. And when we give a delayed booster, only those components will get stimulated, and we get a more specific or more potent neutralizing antibody when we delay the vaccination. So that is a general principle that we use, especially in our laboratory experiments. When we do a hyperimmunization study to generate antibodies against certain proteins, when we decide on an immunization schedule, we try to delay the second dose as long as possible, so that we get the antibodies, very highly reactive antibodies in the second dose. But many times we excuse it only because when the experimental conditions we want to do it, the experiment fast, then we will try to excuse it. But it is not good to excuse it too close. So the delaying is always seems to be better to get a more specific and robust immune response. So that is why that would be one reason why Covishield, because when they introduced the vaccine to the community, there was no long-term studies available at that time. So that is why they initially recommended as a safe practice. Okay, wait after 8 weeks you can take the first dose, 6 to 8 weeks you can take the first dose. But as and when they started getting more information, it is nothing to do with the vaccine availability questions and all that. People are interpreting that when the vaccine became not available, then the interval was expanded. But there is some scientific reasons also behind that. It is not only even when the vaccine if the vaccine would have been available, even then, maybe based on the data that is accumulating, it would have been better to increase the gap between the two injections. In case of Covaxin, this will not be possible mostly because it is an inactivated vaccine, and inherently the memory response or the cytotoxic cell-mediated immune response stimulation will be little poor. So it solely depends on the strength of the adjuvant that they have used. So that would be one reason why they didn't want to increase the gap between these two, because it is a totally inactivated vaccine. And we know that this inactivated vaccine, we keep on taking boosters very frequently rather than a live virus vaccine. So that would be one reason why this Covaxin still they retain the gap the same way, while Covishield we say that we can increase the gap.
So what about the concerns of if we increase the dose too much? Three concerns mainly. Number one, can the declining antibody titers or the waning immunity make the person more susceptible for infection, and thereby because it's a big public health exercise, a vaccinated person becoming positive is not going to do very well for the vaccination process per se, because it is not going to what do you call it? It is not going to encourage faith in people to come out and get themselves vaccinated. So that is one concern from I'm speaking not from a virology point of view, but rather from a public health point of view.
No, let me contribute that from a virology point of view. What we are seeing right now is the mutant viruses is causing infection. Okay. So whether we delay the vaccination or not delay the vaccination, the same thing is happening. Okay. So from the public health point of view, now what we should project is this vaccination will not prevent an infection, but it will significantly reduce the severity in case you get infected. Okay. So suppose we project just like any other disease, like this vaccination is going to prevent an infection or prevent you from getting infected, that will be a misnomer, and that will, in future it may backfire. But if we say that, okay, when we see that a significant proportion of the people are getting infected even after getting 2 doses of vaccine, but their disease severity has significantly come down, and even maybe it should be supported with the data, like how many of them required oxygen, how many of them required hospitalization, how many of them were only mild infection, but that should be supported by data after some time. So those kind of data should be collected and that should be projected. And otherwise, after some time, people will start telling that you have given us all of us, and now this kind of like after those people who got vaccination is going to die in 2 years kind of a scare. So when people, all these false informations will start bouncing back to the authorities or the healthcare providers. So it should be slowly, at least we should be able to tell that this is going to definitely protect you from a severe disease.
Okay. One more question: whether the waning immunity, if that is obviously when you increase the gap too much. So because we have to hit the sweet spot, as you said, it should not be too far away. At the same time, it should not be too close. So can the waning immunity be a substrate for development of mutant viruses? Is there going to be pressure by that for the development of fresh mutations? Or do you think that that is not a factor at all in mutation development?
See, even now, whatever mutant that has developed, the 617.2, at least some portion, some section of the researchers think that it is an immune escape mutant that has come up. Okay. So in any community which is partially immune, whenever a virus is infecting and replicating, there are chances of immune selection happening, mutations happening. So whether it is high neutralizing activity, complete infection, maybe that situation will be different. But if it is a partial kind of immunity, there will be some mutant selection that is happening. But that mutant may not infect the same individual, but it may go and infect another individual who is having a different immune profile. So that kind of, see, that is what is happening with influenza also. So same kind of situation may happen with the SARS-CoV-2. We cannot rule it out.
Okay. What question to you, Madam Sitara, Madam? That is the increasing gap between the two Covishield vaccines is of great public concern, because even the public is now started to say, as Srikumar sir has said, even they might not understand the science behind it, so they might just say it is probably because of vaccine shortage or something like that. From a public health point of view, and I will just put that question not only to Sitara Madam, but also to Dr. Anup as well as Dr. Anju, whether because as epidemiologists, whether going for a second dose and thereby increasing efficacy from, let us say, 80% to 94% is worthwhile. Let us say you have immunized 1 million people, and then you're going to immunize 1 million people again after 1 month, and in those 1 million you're going to increase efficacy from 80 to 95. Or is that money better spent in vaccinating another 1 million people and raising their immunity from 0 to 80%? So from a public health point of view, which would be better?
Sitara is there. It was a question to her. She was.
I think she is not there at present. You can take up the question, ma'am. Okay.
No, see, the evidence came about this shift best efficacy at 12 weeks came long back. So it actually came when we were all about to do the second dose. But then Government of India took a long time to change it to 84 days.
No, not even second dose, madam. I can, because it is in the first dose of Covishield, in the package insert itself, it is there that at more than 12 weeks, it is the efficacy is 80%. So all of us.
But I think the studies came out somewhere around 30 days after we started the vaccination.
No, so, the studies actually, right, go ahead, madam.
Yes.
Go ahead. Yes, right.
So the thing was, we were also thinking that the government will change and increase the dose, but then it really took a slow turn. First, we made it 42 days, then 84 days. As you said, there is a great public health misconcept that we are pushing the date because of the lack of vaccines. But as Sir said, it's a question of I think it will need a lot of cost effectiveness or cost benefit ratio analysis to comment on your very specific question as to whether to vaccinate 1 million with one dose. So I don't think I'm in a position to answer that. But one thing I want to tell you, see, efficacy is in the vaccine to the candidate. In between, there are a lot of things involved, shifting the vaccine from the company, the manufacturing site to the state, then storing this much amount of vaccine, transporting it, getting the data, documentation, scheduling it. It's a big job. So there are a lot of other factors that determine the gap between the vaccine, and I'm sure that efficacy in the lab is one major point, but there are other things involved. So I think ICMR experts must have really looked into the issue and come up with this 84 days gap. I don't know whether Dr. Sitara has anything to add to it.
Ma'am, sir, ഫസ്റ്റ് ഡോസ് കഴിഞ്ഞുണ്ടാകുന്ന പ്രൈമറി ഇമ്മ്യൂൺ റെസ്പോൺസ് വീക്ക് ആണ്. അപ്പം നമുക്ക് സെക്കൻഡറി ഇമ്മ്യൂൺ റെസ്പോൺസ് ഉണ്ടാകാൻ ഒരു സെക്കൻഡ് ഡോസും കൂടെ വേണമല്ലോ. അപ്പം ബെറ്റർ 2 ഡോസും എടുക്കുന്നതായിരിക്കും എന്നാണ് തോന്നുന്നത്. കാരണം നമുക്ക് ഇതുവരെയുള്ള ഡേറ്റ വെച്ചിട്ട് ഫസ്റ്റ് ഡോസ് എടുത്തവരിൽ 1297 പേർക്ക് വീണ്ടും റീഇൻഫെക്ഷൻ ഉണ്ടായി. പക്ഷെ സെക്കൻഡ് ഡോസ് എടുത്തവരിൽ 384 ഉണ്ടായുള്ളൂ. നമ്മുടെ ജസ്റ്റ് കണക്ക് വെച്ചിട്ടുള്ളതാണ്. ഇതിൽ നോക്കുമ്പോൾ നമ്മൾ 2 ഡോസ് എടുത്താലാണ് നമുക്ക് കുറച്ചും കൂടെ ഇമ്മ്യൂണിറ്റി ഉണ്ടാവും. സെക്കൻഡറി ഇമ്മ്യൂൺ റെസ്പോൺസ് കുറച്ചും കൂടെ വരുമ്പോൾ സെക്കൻഡ് ഡോസ് കൂടെ കഴിയുമ്പോഴല്ലേ വരുന്നത്. അപ്പം കൂടുതൽ 1 മില്യൺ ആൾക്കാരെ ഫസ്റ്റ് ഡോസ് മാത്രം എടുക്കുന്നതിലും നല്ലത് 2 ഡോസ് എടുക്കുന്നതല്ലേ.
2 മില്യൺ ആൾക്കാർ ഫസ്റ്റ് ഡോസ് മാത്രം എടുക്കുന്നതാണ് ബെറ്റർ ആണ്. 1 മില്യൺ 2 ഡോസ് കൊടുക്കണം. ഓക്കെ,
ഞാൻ എന്റെ ഒരു വിയോജിപ്പ് പറഞ്ഞോട്ടെ. No, I think I would prefer for 2 million people taking single dose, because even after taking 2 doses, we are not able to protect the individual completely. But there is also some studies which says that it gives a single dose alone, it will give around 30% protection. So, but one point is what we should see is what happens after first dose and when the infection acts as the booster dose, kind of. So, whether the disease profile has changed drastically, whether in spite of the individual getting an infection, whether severity has come down drastically. In that case, I will go for 2 million people getting vaccinated with single dose, so that we can prevent hospitalization or even the ICU. So if there is some information on that, then definitely that will be very important. Especially in a situation where we are facing a drastic shortage of vaccine, and also we are in the peak of the pandemic. And this is a very unusual situation, and this is the first time we are getting the vaccine ready at the peak of a pandemic. And maybe this is a very unique situation. Never it happened in the history of our medical science. So we may not, we may not be in a position to answer this, but if we can think in those lines, whether anyway, this is not, even 2 doses is not going to completely prevent infection. So with single dose, whether there is significant reduction in the severity of the disease, then go for vaccinating as many number of people as possible.
Thank you, sir. Thank you. A couple of quick questions. I think I'll just handle that. The patient with CKD on dialysis, obviously there's no problem with taking the vaccine. Neutropenic patients, if you are not having fever right now, then suppose you are on cancer chemotherapy and you're having neutropenia, there's no problem in taking the vaccine, but obviously your immune response is not going to be very optimal. Sir, coming back to you, one more question. That is, actually, 2 more questions. What about a third dose? Do you require a third dose? Number 1. Number 2, is there any way in which to identify whether a particular mutant strain came out naturally, or did it come out under the pressure of, let us say, immune selection following vaccine? Is it possible in the lab to differentiate between a natural mutation and one which evolved under our vaccine escape mutation?
The first question about the third dose is actually we may need that, but we may not call it as a third dose. Maybe it will be another vaccination that we are taking, because by the time the third dose, it will be after 1 year or so. It will be another new vaccine that we will be taking with the mutant, but we may need subsequent doses, because we don't think that this is going to go away in a year or so. So we may need the additional vaccination. And maybe the data will emerge how long the immunity stays. And even now, when more people are doing the antibody detections and also neutralization assays, and to see whether there is a neutralizing titer that is there in the individual. So maybe more assays will come down and we will have more information on that. But definitely, I think we may need another dose after some time. How long is again a question, but we will have to wait and see. Then second thing is, within the lab, we can do this kind of studies, like whether mutant viruses emerge because of the immune pressure. Only the antibody kind of pressure we can give. We can grow the virus in presence of diluted antibodies and see whether mutant viruses are emerging. There are studies that is being done many places to look into the new variants that is emerging. But that may not be typically representing what is happening in a population, because in the population there are so many other factors involved. But at least we can have some idea whether this virus is undergoing. So we call it as in vitro evolution techniques and all that. We can do that.
Okay, then thank you, sir. So if there are no more questions, I think we can wind up. It's been already about more than 1.5 hours. So,
see, I could see one question here, whether we are doing any research on gain of function viruses. See, actually in India, we are not doing the whole virus based gain of function or loss of function kind of studies, but we are, most of the virologists or any molecular virology person working with viruses, they will be looking at individual proteins and making mutants of that proteins and looking at the gain of function or loss of function. Those kind of studies, even in our own laboratory, we are doing with chikungunya and dengue viruses. That is based, focusing on certain particular proteins which we think that will be functionally relevant. That we are doing, but not with the whole viruses. I don't think anyone in India is doing that.
So I think perhaps that is all.
Can I say something?
Yeah, sure.
It's to Dr. Sitara. You have committed to everybody getting vaccinated with 2 doses, and most of us have reached our 84-day this thing. So you you're committed to that. You hope we will be providing us with the second doses very soon.
Madam, your promises. You are being.
You're committed to earlier the better 2 doses.
We are holding you to your promises.
Yeah, so we are expecting to get our second doses very soon to medical college, to all our health workers.
Okay.
Thank you, Sitara. Thank you.
So let me thank all our panelists on my behalf. Srikumar sir spent valuable time with us, almost 2 hours. Dr. Anuba, Dr. Anju, Dr. Sitara, who is rarely off the phone. Even she has been here for 1.5. That by itself is a miracle for 1.5 hours. So thank you all for a valuable contribution to this very, very interesting and informative discussion. Thank you all.
Thank you, sir. Thank you.
Thank you. Thank you all.
Thank you.